The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to the Board of Pharmacy webinar today. I'm Tom Glinski, Chief Inspector with the Board. My guest today is Michael Boger, the Administrator from the Bureau of Narcotics and Dangerous Drugs, and he's going to give us an update. It's been a couple years since we had Mike here, so it'll be good to have an update from BNDD. Before I turn it over to Mike, just a few things to tell you. If you haven't been on our webinars before, you're in listen-only mode. If you're having issues with audio, you do have an option to choose the telephone option instead of the internet if you're having trouble getting the audio over the internet. This has been approved for 1 hour of pharmacist continuing education. You must be officially signed up and logged on to go to webinar via your computer. If you're in a room with multiple people watching one computer screen, only one person will be getting the CE. At the end of the program, you must answer the post-survey questions to get your CE. I'll go over more instructions at the end of the webinar about how to get your CE. And our CE is not submitted to the CPE monitor, so you will need to print keep your certificate that the board mails you. If you would like handouts, they are posted on the board's website. Under the section announcing the webinar, there's now a link to the handouts. We do make a recording of the webinar, and we post it out on YouTube. It could take about 3-4 weeks before it gets there sometimes. You can find this webinar and previous ones on our publications and resources page, and there's a section listing all our previous videos and webinars. You do not get CE for watching one of the recordings. We took questions in advance. We have a lot of them, but if we have time, we will try to answer questions that come in during the webinar. If you would like to send us a question, go to your GoToWebinar toolbar and type in your question and hit send. So now I'm going to turn it over to Mike. Thanks for coming today, Mike.
Okay, thank you very much. We always like to do this, and we appreciate being able to reach out and do all the education activities we can to answer questions and clear things up and try to prevent any issues before they occur. The things I want to cover today are some of the hottest topics that we get routinely on daily calls from pharmacists, from retail and hospital and all the different areas out there. I want to talk about everything that's going on in our department and the BNDD involving opiate abuse reduction. That's a big topic that's in the news. Talk about some pharmacy theft prevention conferences that we're planning and working on. What rules is BNDD updating right now? Some of the hot topic questions that we know we're getting from pharmacies on a daily basis. I'll cover that, and then we'll kind of go into answering some of the questions that have been submitted. The opiate abuse and the overdoses and the deaths is something that has been in the news a lot during the past couple of years. And it's in the news every night, and we've been working on this also for the past couple of years. We have been invited to Washington, D.C. several times to meet with different agencies, the DEA, the FDA, Health and Human Services, about the opiate abuse that's going on nationwide. Not only has the BNDD gone, but so have people from the Board of Pharmacy, MoHealthNet, and the Department of Mental Health. And we're looking at this from education, prevention, best practices. Do we need new laws or regulations out there? The 4 boxes here below is what the federal government gave us. They kind of called this the 4 legs to their 4-legged chair. These are things that they would like for all the states to do, because it is shown that in those states it's had some impact. So obviously, number 1, have a prescription drug monitoring program. Get a PMP and use it if you can. The second thing was try to get some type of opiate prescribing guidelines out there into the hands of the physicians and the prescribers to give them more education about dosing levels and how to treat chronic pain. The third thing that they asked us to do was look at having a specific license for pain clinics. Down in the southeast part of the country, in Florida and Georgia, anybody could open up a pain clinic, stick somebody in there. A lot of questionable prescriptions were being written, and they have all passed laws now that regulate a pain clinic, and they have to have a license and be inspected, and they require board-certified pain management specialists. And if you hold yourself out to be a pain clinic, they have put more regulations on you. A lot of those clinics closed up and left, and they're moving to Missouri. So there has been legislation filed this year that's looking at should the Department of Health license a pain clinic the same way that we do the hospitals and the surgery centers. So that legislation is still going through the legislative process. The other thing they asked us to do was look at expanding our treatment abilities. There's not enough narcotic treatment programs out there. So, we're supportive when doctors want to go to the mandatory training so that they can prescribe Suboxone, office-based opiate therapy, things like that. Right now in the state of Missouri, there are 248 of those doctors that can see patients in their office and prescribe Suboxone to them. There's also legislation out there that will expand the use of naloxone or Narcan. It's on every ambulance, and it has been. Well, last year they passed a law that said any first responder can carry it, so they expanded it to law enforcement. That's where we are right now. There's legislation pending that they have written that would expand that so that there's one bill that says let it be sold over the counter. There's another bill that says that a doctor or someone can stock it in a building in an emergency kit. So if you have a school or a town hall or a community center where you may have a defibrillator or you might have an EpiPen, that you could put Narcan in there. So they're looking at that. But once again, that's current legislation that is being looked at. It has not passed yet. But these are some of the things that we are pursuing, as all the other states are also pursuing, that the federal government wanted. We started a work group because we went to these meetings in Washington, D.C. We just can't come back and do all these things alone. Drafting new legislation, having rules, we needed the help of the other departments and associations and other people in the industry to solve these problems as a group. So we have formed a work group that's been meeting for the past year and a half or so. We've been meeting almost quarterly, and we're looking at all of our goals, our ideas, our suggestions, what we could be doing. Patient education about how to take care of their medicine, doctors' education about proper prescribing, getting a PMP, things like that. As you can see by this list, it's not just a BNDD issue or Board of Pharmacy issue. It's all the licensing boards, the DEA, law enforcement, the treatment people from mental health providers, and then all of our associations. The Missouri Pharmacy Association has been very active, as has our medical associations, the hospital association. The Missouri Hospital Association even came out with their own prescribing guideline document, but it's for emergency room physicians. Going to the legislation that has been filed at this time, as far as Missouri getting a prescription drug monitoring program, there were 2 bills filed in the House of Representatives. 1 bill has been filed in the Senate. The House Bill 1892 is sponsored by Representative Holly Rader of Southeast Missouri. Her bill has passed the House, and it has been voted out, and it is complete out of the House. So now it has crossed over into the Senate. Recently, this past week, it was assigned to a committee, and the committee voted it out due pass, and it has cleared all of its executive committee guidelines. So the next step for that bill is it will go to the Senate floor, where it'll be debated and voted on in the Senate by the 36 senators. A lot of the lobbyists in our group are over there at the Capitol every single day, walking the hallways, questioning those senators, asking them how they're going to vote. Who's a hard yes? Who's a hard no? What do we think the break's going to be? How can we prevent a filibuster? Things like that. But we're watching the calendar because we think that in the next coming week, that PMP bill is going to go to the Senate floor where it will be debated, and we'll see if it passes, and if so, in what form. The major issues that some of the senators continue to have with the PMP bill is confidentiality. They have an issue with all of the prescriptions of everybody going into one database, and they're afraid it could be hacked. Then the other issue is cost. How are we going to pay for it? Even though we could apply for a federal grant and get it, it's one-time money only. And one of the questions that they will ask us is, how are you going to fund this in the future? You have to have a sustainable program. So the cost of how we're going to pay for it also gets debated. On opiate prescribing guidelines, putting a document out there telling doctors what they should or should not prescribe and set limits, that's really an issue for the Missouri Board of Healing Arts. They regulate what is proper medical care. They have not yet put out their own guidelines, but as we all know, the CDC recently published opiate guidelines for the treatment of pain. Our Bureau has saved that and downloaded it. It's on a PDF format, and you can get it from our BNDD website. If you go to the BNDD website and you look under our link to publications, there's a direct link there to the CDC's opiate prescribing guidelines. And we made it very clear that we posted that as an educational guideline to assist doctors. They're not laws, and they're not statutes and regulations, and they cannot be enforced. So if that guideline suggests 90 morphine equivalents per day and some doctor prescribes 95, we can't come in and do anything about that. This is an educational guideline, and the BNDD doesn't go in and question clinical therapeutic review. That's what the boards do. And then, as I said earlier, the Missouri Hospital Association has put out a totally separate guideline that they have created with their hospitals, but it's for emergency room doctors. Emergency room doctors provide emergency care. They should be writing a prescription that just gets a patient through an emergency period. They don't suggest a 30-day supply. They should get more like a 5-day supply, and they talk about that. So there's a totally separate guideline out there for emergency rooms. When it comes to pain clinics, right now clinics are not licensed by anybody. The BNDD and the DEA, we register the individual physicians, but not the clinic as a business. So anybody can open up a clinic, run a clinic, own it, and put doctors and nurses in there, and they don't get a license for that. So that's what Representative Swan has filed this House bill to set some standards for everything. It would allow the department to promulgate some rules about cleanliness and record keeping and security and board certifications and things like that. Now, this is if they are holding themselves out to be a pain management clinic. But it's in the legislative process, and during the last week alone, we've seen a lot of amendments get added to that, and we're getting down where there's only 2 weeks left in the session. So legislation is changing every day, and it's being amended. So we are tracking that to see how it changes. Medication-assisted treatment, or MAT, these are the bills that would allow Narcan to be used on a wider basis. Representative Lynch filed House Bill 1568. where a physician can issue a standing order for a person or an organization to stock naloxone in a kit, in a building, something like that. It also provides, it has a civil immunity clause that would protect people who needed to get into that emergency kit and use it. And then, as I said before, doctors who are allowed to provide Suboxone out of their office. We have 248 of those right now in the state of Missouri, and it's increasing. We get calls a few times a month where doctors call us and they want to know how they go get certified to do that, what training do they take, and how do they get their DEA number amended so they can do that. So that is a growing field. We have a Senate bill 1136 filed by Senator Sater that strictly addresses the Missouri Board of Pharmacy. It addresses fees that are out there that the board doesn't want to be swept away. There's some money out there that we could use that we are in discussion between the Board of Pharmacy and the Department of Health and others that we could use to have educational seminars, patient safety brochures, and work on some of this prescription drug abuse epidemic that we have across the board. But in order to spend the money, we have to have legislative approval. So Senator Sater, who is also a pharmacist, has sponsored this legislation that would allow us to use pharmacy funds for pharmacy education activities. Something that we are in the planning stages for. They've not been finalized, but BNDD has noticed over the past 2 years that our major source of diversion is from pharmacy technicians. Every once in a while, a nurse may steal drugs out of a hospital. We may have a doctor writing false prescriptions or taking drugs out of his practice. But by far and away, the biggest source of diversion is pharmacy technicians because they are stealing entire stock bottles and several times a week. And it's not uncommon now for us to get loss reports where a pharmacy has lost 30 to 40 to 80,000 doses before it was revealed. So we wanted to try to come up with something with the Board of Pharmacy to address a pharmacy theft prevention conference. The DEA did this several years ago, but we would just like to be able to go around the state in the future, offer some educational opportunity where we invite pharmacists and their employees in to talk about, the theft, what's going on, how it's happening, best practices, how to identify some of these impaired coworkers. The DEA has agreed to participate to talk about what happens if you discover a burglary, what to do during an armed robbery, and just talk about these things. But right now we are in the planning stages, so hopefully if we can get this developed, we will be rolling something out later in the summer. BNDD has some rules that we've been working on that we would like to have updated. That is a lengthy process. It has to go through the department. It has to go through other departments. It goes through the legislative process and all the way up through the governor's office before we finally file them and get them out there for public comment. But 3 of the things that we are updating that were in the process is update the list of controlled substances and their exemptions. We want the Missouri list to match the DEA list, so we're working on getting that updated. We want to go along with what the DEA is allowing and allow pharmacies to have drop-off disposal boxes. If a pharmacy chooses to collect unwanted medication from patients, then we're going to adjust our rules so that they can do that. So that's one of the things that we have drafted that is undergoing review. And then the BNDD wants to amend and update how emergency kits are handled with pharmacies and nursing homes, long-term care facilities. And BNDD wants to be more consistent and come into line with what the DEA has always said. So we want to just say that, yeah, they can have an emergency kit and they can get it from a pharmacy, and It'll be the nursing home's job to keep it locked up and secure and do the record keeping, and they can handle that relationship and work that out with the pharmacy. And the current regulation addresses and talks about prescriptions in there, and we want to take that out. So that's what we're working on. Getting into some of the hot topic calls that we get on a routine basis in the Bureau, we regularly get calls from a doctor or a pharmacy that says that they can't fill the prescription because the form does not comply. They have brought a prescription form to the pharmacy that doesn't meet the requirement. It doesn't have 2 lines at the bottom. It doesn't say dispense as written or substitution permitted. And that law is not a law or rule of the BNDD or the DEA. It's not something that we speak to or enforce. That is something that's in the chapters of the Board of Pharmacy. So we refer them to that. But it is confusing for the doctors because the Board of Pharmacy requires certain things. The DEA requires certain things. And then Medicaid, Medicare, MoHealthNet requires certain things. So when a doctor wants to make prescription pads, they have to go to 3 separate agencies and look at 3 separate sets of statutes to figure out how to make a prescription pad. And that's hard to do. They don't know where to look. We've tried to fix that. We have asked the legislature to just come up with one law, one-stop shopping. Let's tell people what needs to go on a prescription form. And we've tried that. We haven't been able to get the legislation through. But for the most part, if the pharmacies tell the doctors what the problem is, the doctors are pretty good about fixing it. They just need to know what's going on and what they need. But that issue of signatures on the bottom left or the bottom right is in the pharmacy law. It is not in the BNDD. I think this is everybody's favorite topic. We get calls on this almost every day. We're going to spend some time clarifying and going over mid-level practitioners, what they can prescribe, how much, and oh my gosh, what if they come from another state? There is a lot of confusion over this. When this law was written towards the end of a session in a room, the BNDD and the Board of Pharmacy weren't in there. And this is something that was written, and now we're trying to follow through by making sure that we can provide information so that everybody can comply with it. But our statutes address certain things. 195.070 talks about who may prescribe, and it lists out all the professions there. And then a different section, 195.080, that tells the pharmacy how much you can dispense, a dispensing limit. They're in 2 separate statutes. So in our statute, who can prescribe, the list is right here. Physicians, podiatrists, dentists, optometrists, the people that we are used to dealing with all the time, they have their own section that give them the right to prescribe. Section 2 talks about mid-level practitioners, and they have full authority to prescribe like physicians do in Schedules 4 and 5. For any opiates, they're limited to a 5-day supply or 120 hours. That would be opiates in Schedule 3, and then any opiate in Schedule 2. But in Schedule 2, they're limited to 1 drug, and that's hydrocodone. And then Section 3 is an entirely separate section for veterinarians. Dispensing limits for the doctors, it hasn't changed. Most Schedule 2 prescriptions are written for 30 days or less. They can go over 30 days, up to a maximum of 90, if they give a medical reason. The statute does not define medical reason. What we normally see is 2 things: the diagnosis of the patient and what's their status. The most common thing we see is stable ADD, stable ADHD. As long as they can tell the pharmacy, here's what the patient has, they're stable, here's why I don't want to see them every single month. And that's pretty clear. So schedules 3, 4, and 5, they can go up to a maximum of a 90-day supply. The prescriptions are they're good for 6 months from the date they're signed. And then depending on how much they prescribe at one time, they can have a maximum of 5 refills. Now let's talk about the mid-level practitioners. This would be the advanced practice nurses and the physician's assistants. And now, these limits that you see on this page, they're for Missouri licensed people. This is what Missouri nurses can do and Missouri physician assistants can do, because they put restrictions on the Missouri practitioners. So it's not only the fact that they're a mid-level, but we kind of have to ask ourselves, where did they come from? Where were they standing when they wrote this prescription? If it's a Schedule II, they're limited to hydrocodone only and a 5-day supply. If it's a Schedule III opiate, same thing, it's a 5-day supply. If it's a Schedule III non-opiate, like testosterone, they can have full privileges. And Schedule 4 and 5, full privileges. There are no restrictions on Schedule 4 or 5 or Schedule 3s that are not opiates. And these restrictions are on the prescribers that are from Missouri. These limits do not apply to the mid-levels if they're coming from another state, if the prescription's from Kansas or Oklahoma. The limits change if I'm from out of state. This law was changed strictly really for mail order pharmacies, because Missouri is the home of several large mail order pharmacies that fill prescriptions and ship them all over the country. So it became a problem if they were getting prescriptions from Nebraska and Alaska and New Hampshire, and it's written in a way that can't be dispensed in Missouri because our state limits are different. So they approached the legislature and said, we will always fill Missouri prescriptions the way the Missouri law says. But since we're shipping drugs out of state, if we get a prescription from an out-of-state doctor, can we fill the prescription according to the laws of that state? And the legislature said yes. Now, that requires some of these big mail-order pharmacy companies like Aetna or Express Pharmacy Services, Express Scripts, they now have to know the dispensing laws for all 50 states. But that's something that's on them. If they get a prescription from Alaska, they're going to have to look up and see what Alaska law allows. But that's why they did that. They wrote that law that says that if the prescriber is prescribing from a patient and they're both from another state, then you can dispense it as written according to the laws of that state. So if a Kansas nurse writes a prescription for a Kansas patient, you can fill that according to the laws of Kansas. No restrictions. You just go by what Kansas allows. And I put some examples in here. A doctor in Alaska prescribes for a patient that's in Alaska. Then our limits of Section 195.080 do not apply. You're going to fill that prescription according to what Alaska law allows. And then I continue on. If a Kansas nurse writes a Schedule II prescription for a Kansas patient, it's okay to write that by whatever the Kansas law says. Full privileges for them. But they change it whenever it impacts a Missouri patient. If the Kansas nurse writes a Schedule II opiate prescription for a Missouri patient, they don't address it in Schedule II. They're only placed on the Missouri level, mid-levels, if they're licensed and prescribing in Missouri. The best thing to do is, if you wanted to, go out there to our website, copy that Section 195.080, and it talks about mid-levels in the state, out of the state. what to do if the patients are from out of Missouri, what to do if the patients are from Missouri. So they will allow them to do that 30-day supply in that instance. But that's the confusion. You have to look and see where the prescriber is, and then look and see where the patient's from. And reading the language has always been somewhat confusing. So I'm trying something new this year. I'm going graphic, and I put this slide out there that you can also print out and hang on your wall. Maybe this will help you. But if you look on the Missouri side, a doctor's going to prescribe to the patient. Those laws have not changed. Most C2s are 30 days, schedules 3 through 5, 90 days. If you're a Missouri APRN, I've got what's allowed there. C2s and opiates, they're limited to 5 days. But C3s, Schedule 3s that are not opiates, and then all other Schedule 4 and 5, they can do the full 90-day prescribing privileges. And then the same thing, if we cross the border, Kansas doctors can prescribe to their patients according to Kansas law. The Kansas APRNs can prescribe to Kansas patients per the Kansas law. And then we look at the green line. That's when somebody's crossing the state. If that doctor wants to write a prescription to a Missouri patient, or that nurse is, then you can see in the green coloring there that they've rewritten that law again so that it's 30 days and it's 90 days. Because there are restrictions on mid-level prescribing, but they put the restrictions on the mid-levels that are from Missouri. There's my contact information. One of the things that we'll put out there, because our phone lines are always busy and you might have a question, the best, fastest way to get a hold of us at any time through the day is to use that email address. That way we don't have to play phone tag and you don't have to wait on the phone or interrupt patient care. You can email us a question. We'll look into it. We'll find up the answer and we'll send it back to you. So you don't have to stop what you're doing or interrupt your day. You can ask us a question. We'll look up the statute, the reg, or whatever. We'll find an answer. We'll send it back to you. You'll not only get a faster answer that way, but you'll get it in writing. So if someday, our inspector shows up and you're discussing something, you can say, I've got it right here. Here's an email, and hopefully that'll help you out.
Okay, we're now going to answer some of the questions that came in. If you'd like to send us a question, go to your toolbar, type it in, and hit send. And we're going to start off with some of them that came in advance. And some of these may have been addressed in your slides, Mike, but we'll go ahead and just reiterate the correct answer again for them. So we have a question about what does a pharmacy need in order to receive controlled medication C2 prescriptions electronically?
There's an entire set of federal regulations out there that the DEA has for electronic prescribing of controlled substances. It's pretty voluminous. There's a lot of rules. When the BNDD updated their rules, we just kind of said, ditto, you can participate in electronic prescribing pursuant to the federal guidelines. The software, the computer system, the things that you're going to use need to be DEA compliant. They have standards and security, and they have an auditing system for the doctors and everybody. When a doctor wants to do electronic prescribing, they have to show that they're using a software that's been tested and audited and approved. And all of those rules are out there in the federal regulations under Chapter 1306. But what you want to make sure of is that the two things, when the doctor sends it from their computer, it should arrive on the pharmacy computer, and it cannot go to the fax machine. So don't let the practitioners electronically prescribe and send it to your fax machine. It has to go from computer to computer. One of the DEA rules is what starts electronic has to stay electronic, and it does not become paper. So if you are set up so that you can receive electronically, dispense it, you can archive it, you can pull it back up, that's what the DEA is looking for. But you can contact your local DEA offices if you have questions, if you want them to look at it, or if you want to ask them if your software is okay. We would defer that to the DEA.
Okay, you talked about conversion from electronic to fax, but we have someone asking, can a physician electronically sign a hard copy prescription?
No, if it's hard copy and it's paper, the doctor has to manually sign it in ink before they fax it. So if they are doing truly electronic prescribing, it will have their electronic signature on it, and it'll be transmitted to your computer, but it can never become a fax. And then likewise, if a doctor wants to fax you a prescription, it has to be manually and originally signed first. Then they can fax it. So one of the problems we have is when a pharmacy gets a fax prescription and what's on there is an electronic digital signature, that is not allowed.
Okay, we have someone asking, are there any special requirements for electronic C2 prescriptions compared to electronics 3 through 5 prescriptions?
That also we would defer to the DEA. They do allow the electronic prescribing and dispensing for all schedules, 2, 3, 4, and 5. They're all going to be in your archive database.
We have someone asking for your email address again, so I'm going to back up a screen and leave that up for a little while.
Okay.
Next questions have some supply limit questions here. We have someone who wants to know if a prescription has a refill, a 90-day refill. Can you refill that on the very last day before it expires? Is there anything that would prohibit you from doing that?
Not under the law, because the law says that the doctors can write for 90 days. The law says that a 6-month supply is the most they could ever give out. So I would say that first prescription is going to be a 3-month supply, and then it should only have one refill on it because the prescription's only good for 6 months. So as long as they're filling it within 6 months, yeah, they could get one prescription on day one and then come back in almost 179 days later and get that second one, because legally it's inside 6 months. And we don't have a law that says they can't. The law says they can.
Someone would like to go over what is the valid reason that could be listed for a C2 prescription greater than a 30-day supply?
The statute says that the doctor has to provide a valid medical reason, and they didn't define what they wanted by medical reason. So what we are normally seeing and accepting from all the doctors is letting the pharmacist know why you want them to have this extra extended supply. So we normally see a diagnosis and then something about the status or the condition of the patient. So we will see stable ADD, stable ADHD, stable chronic pain, something like that. Let me give you some things that are not medical reasons. Things that are not acceptable is patients going on vacation, patients going to be gone traveling, patients going back to school, patients leaving on military service, and also something that we've seen is they want to extend the supply because the patient gets a price break from their pharmacy if they buy a bigger quantity at once. That is not a medical reason.
I've got a couple questions related to the issuance of multiple C2 prescriptions on the same day. We have someone wants clarification on what's the maximum day supply. They say they have a doctor who believes he can write one prescription and then give out 3 more 30-day prescriptions, so that'd be a total of 120 days. They're asking, is that legal?
It's a 90-day supply total. 90 days is what is in the statute. It can be extended up to the 90 days, not add a new 90. That matches the federal law. When they want to do that prescribing in advance and put do not fill until dates on it, they can issue as many prescriptions as they want as long as it is just a 90-day supply. So depending on how much the doctors trust the patient with medication, we've seen them write a 10-day supply and then issue 8 or 9 prescriptions. Or we've seen them do a 1-month supply and issue 3 prescriptions. We've seen a 15-day supply and they issue 6 prescriptions. They spread it out according to what they want to trust the patient with, but they can't go over 90 days.
On the same topic, we have someone wanting to know, on those 3 prescriptions, can they all be written on the same piece of paper, or do they have to be 3 separate pieces of paper?
We don't have a law or a rule that says prescriptions have to be on their own piece of paper. So a doctor could pull out a prescription form and put multiple prescriptions on there. They can do that. We don't have a law that tells them that they can't. Now, what that means to the pharmacy is sometimes you'll get a controlled drug and a non-controlled drug, or you'll get a Schedule 2 and then a Schedule 4. And what we normally see is that the pharmacist may photocopy those so that they can file them in their separate drawers. But, right, the doctor could write all the directions and put it on one form and say, here's a prescription, and then add all the other directions across the bottom.
Okay. The next group of questions kind of deal with mid-level practitioners. Someone just would like clarification. Can a nurse practitioner write a 30-day supply for a non-opiate controlled RX?
Yeah, they could. We have nurses that are writing for a full month supply of Xanax and issuing 5 refills. If it's not an opiate, they are not restricted.
Clarification on the C2 hydrocodone. Is it just hydrocodone? Is it just hydrocodone acetaminophen products, or does it include single ingredient hydrocodone products for the C2?
The statute says hydrocodone, and that's where it stops. So it would be all hydrocodone products, no matter what they are. So it could be just the straight hydrocodone. It could be hydrocodone with the acetaminophen. It could be a syrup. It just says hydrocodone. So it's all Schedule 2, so it all goes into that same category.
We're asking someone if you could just clarify the differences between any limits on a nurse practitioner versus a physician assistant.
There really aren't any on the prescribing. They're both mid-levels. They both have a doctor that they're in a relationship agreement with. The legislature gave them both prescribing privileges for schedules that match. It's the same thing that they match. Schedules 3, 4, and 5 for the non-opiates, they're okay, but they restricted their opiates to 5 days. And if it's Schedule 2, it's strictly hydrocodone.
We have someone asking, is there a limit on how many times a nurse practitioner can write a 5-day supply of hydrocodone?
There's no limit on that in the statute. It just says that a mid-level can write hydrocodone or any other opiate and be limited to a 5-day supply. And, of course, those aren't going to be refilled. So there's nothing that would stop them from issuing a brand-new prescription every 6th day, because that would be a new prescription, not a refill. So that's the way that the legislature wrote the bill. They can just keep writing new prescriptions.
We have just a question about out-of-state C2 prescriptions from out-of-state mid-level practitioners. Can you fill them, and what limits apply to them? Really
none. We covered that earlier. It's already on the other charts. You can fill the prescriptions from out of state, fill it according to the laws of their state if it's from Kansas, but if it's from our state, use what's in our limits. But you can fill them, and then you just fill according to what the limits are in that state.
Okay, our next couple questions deal with applying the both the physician and the nurse or the PA's name on the label. The requirement that you must do that for Missouri mid-level practitioners, does it also apply to out-of-state mid-level practitioners whose prescriptions are filled by Missouri pharmacies?
It applies to all because they put it in a statute that tells all pharmacies how these drugs get labeled. That's something we've been working with the legislature on. We would like them to change that back. What goes on a pharmacy label is something that the FDA and the DEA worked out many years ago, and all the states comply with it. And if you're part of a chain drugstore, it lets you have one software that works nationwide. But all of a sudden, a few years ago, when Missouri said, if you're a mid-level practitioner, you have to put your doctor's name on there. Now, we've just changed the labeling law just for the state of Missouri. So that's kind of a pain for everybody that's in a nationwide business. But they put it in section 195.100.5, and it's an instruction to all the pharmacists that says anytime you dispense any controlled drug for a mid-level, the doctor's name has to go on there. And that's for all the prescriptions. It doesn't say just for Missouri only. So that would apply to all of them if they're from a mid-level.
And on that same topic, does it matter where on the label? Can you put the supervising physician's name in parentheses in the direction section of the label?
That would be okay with BNDD because we don't get into where it's at or what size it is or where you're going to place it or what color. So in our eyes, if you put it on the labeling anywhere, you've met the statute.
Okay, we have someone asking you to discuss controlled substance partial fill requirements.
Okay, and these are we have two different statutes for that, and ours matches the DEA. It depends on why you're doing the partial filling. If the patient walks in with a prescription for 60 and you are out of the drug and you don't have all 60, if you only have 30, then you can partially fill and give them 30, but then you have to give them the remainder within 72 hours. That law has been out there for a lot of years. The other thing that we're running into now is another reason. The patient may want to partially fill their prescription because it's all they can afford. Although I have a prescription for 60 doses, I can only afford maybe 15 at a time, and that's okay. The DEA allows that. BNDD would allow that. You can dispense 15, and you just log in the date and that I got 15, and I have 45 remaining. And I can keep coming back and keep coming back until I have used up that prescription, until I've used all 60. Those are not considered refills. So if I have a large prescription and I have a prescription for 90 and I want to come back and get 15 at a time, well, that's going to be 6 times. Well, that's okay. We don't consider it a refill unless you are refilling the entire amount and giving them the full 60. That's a refill. But partial filling is okay. The DEA rule just says that you watch out for 2 things. Number 1, make sure that you never dispense more than what the doctor originally allowed. And then all that dispensing has to be done within 6 months. But partial filling is okay regardless of how many times it is. Just don't exceed the prescribed amount and stay inside the 6-month date.
Okay. Can a pharmacy fill controlled substance prescription if the prescriber is deceased? And what's the status of refills, remaining refills after a prescriber dies?
That prescription would still be considered valid because the BNDD and the DEA, we don't have any laws that says it's not. It would be a nightmare for us if all of a sudden we had a rule or a law that said when a doctor dies, all of his prescriptions and orders terminate. Because what would happen to the people in the hospital or the nursing homes or the hospice care if you just told these people you have to go find a new doctor, make a new appointment, get all new meds. It might take you a few weeks to a month, but your doctor died, so we're going to stop all medical care. We do not want to do that. When the doctor was alive, he wrote a prescription. It was legal and it was valid. And then when the doctor dies, there's nothing in the law that terminates that prescription. So we go ahead and we tell the pharmacies, honor those prescriptions, dispense them as written until it runs out, even the refills. That would be fine because the patient's going to know they're going to have to go find a new doctor and they'll be getting a new prescription from a new provider. But the prescriptions are good after the doctor is deceased.
Next question has to deal with some compounding issues. What's the best way to track controlled substances that have been used in compounding, and should the compound logs be separate from non-controlled substance compound logs be separated from non-controlled substance compound logs?
What we've seen when we're just looking at the records in the pharmacy, there's a DEA rule and a BNDD rule that controlled drug records are kept separate than all the other legend drugs. So yeah, you would, in compounding, products that have just non-controlled drugs would be in one area or in one file. Anything at all that's a controlled substance goes into another file. There are separate files if they're controlled drugs or if they are not controlled drugs. As far as the best method for keeping that, that's kind of the pharmacist's choice. We've seen like spreadsheets and logs. We've seen something on a computer. It kind of goes with what drugs you normally compound. Is it the same thing all the time? How big is your business? How many scripts is it? But if you're prescribing the same thing, you know, most of the time, they have the prescription. They'll have a sheet out there. They're using the same ingredients. They measure it out, and they write it down each time, and they keep a running record.
Can a pharmacy change the do not fill before date on a C2 prescription if the prescriber is agreeable?
I would think that's one of those things that they could, as long as they call the doctor first, verify it. It's not name of the drug, it's not name of the patient or physician's signature. It's one of those things where you call the doctor, you discuss the change, and if it's okay, you document it. You know, the date, the time, who you spoke to, what they said. Just make sure that the doctor is agreeable to it. And as long as you've documented it on the prescription, that would be okay with BNDD.
The next two deal with some security. Do C2s have to be under lock during business hours even if the pharmacy is locked?
Yes. The BNDD and the DEA laws say that controlled substances in the Schedule 2, we'll talk about the Schedule 2 safe for pharmacies. It has to be locked. If it's standing open, it's not locked. If it's just sitting out on the shelf, we know that standard practice is when we go into the pharmacy, if there's a Schedule 2 out, it's because somebody has it. They are in the process of filling and dispensing. And then when they're finished with that, they put it back in the safe. But the safe needs to be locked all day long.
And then someone wants to know, for fast movers items like hydrocodone, can they be left out on the counter instead of locking them up during the day?
No, not legally. That would not comply with the DEA requirements.
Okay, we have someone asking about pseudoephedrine database. If they only do it by prescription, are they required to do the DEA combat meth self-certification, and are they required to report any of the cells to the database?
No, there's no reporting requirement. Both the federal government and the state government gave pharmacies that option. You only report to the Sudafed database if you're selling over the counter without a prescription. Anything you sell by a prescription is exempt from the database and that Combat Meth Act. So I think we have like 46 different jurisdictions in Missouri where pharmacies sell by prescription only. They do not report to our database at all, and they don't report to the DEA.
Could you explain when a retail pharmacy could witness waste a controlled substance?
I guess we're talking, it depends on like the setting, retail.
I think that, yeah.
Does it say pharmacist or pharmacy?
It just says a retail pharmacy.
A retail pharmacy. Witnessing, I don't think there's any restrictions on witnessing. If a patient came in and said, I want to destroy my medicine right here, will you watch me? I mean, all you're doing is watching. We don't have a law against that. It would be different if you said, I'll take those for you, or let me take them into my store. That's different. But they're just asking you to witness. It happens in the pharmacy all the time in a hospital where, the nurses or the doctors, the anesthesiologists are bringing things back to be destroyed. But in a retail setting, we really don't see. I guess that could change now if we have, and they're probably not controlled drugs, Tom, but we're seeing more retail pharmacies in some of the chain stores, grocery stores, open up a clinic next door. So when you go to some of the big grocery stores, there's a pharmacy, there's a nurse or somebody right next door. They might only be doing vaccines or certain kinds of medications. If the nurse gave somebody a shot of something and wanted somebody in the pharmacy to say, hey, will you watch me waste this? You could do that. You're just witnessing that they didn't do it alone. Another person was there. We don't have any law that says you couldn't.
Okay, we are about out of time. Before we go, I want to thank Mike for coming today. It was good to have you here to answer some of the questions and give us the update. We had a lot of questions submitted that we didn't get to. If you'd like, Mike says you could just email them to his email address. If you have questions remaining, and he would, someone there will get back to you on those. There's a lot of them, so it may not be today.
Well, if we have hundreds and hundreds of people out there listening online, and there's a lot of them, we'll do as many as we can over the next several days till we get them done.
Okay. Our next Lunch with the Chief webinars are scheduled for Thursday, August 4th, and Tuesday, October 25th. We haven't announced it yet, but watch for our email alerts. We are planning a special webinar on June 8th. The topic is going to be ethics. We will have a guest to come talk about pharmacy ethics. That will be on June 8th, and we'll be sending out an email alert closer to time to register. Just to go over the continuing education instructions, when I close the webinar, a little window will open up saying the webinar has ended. You will need to close that, and then a survey of questions will pop up, and you need to answer those and submit your answers back. If you're using a smartphone or a tablet, you may not receive the survey. We've been told in the past people have trouble receiving them on those devices. If you don't get your survey following this, you can email compliance@pr.mo.gov, and we will email the questions to you. If you do that, you must get them back, the answers back to us in 48 hours. We will mail certificates out in approximately 30 days, and again, we're not reporting this to the CPE monitor, so you will need to keep your certificates. And we will post the recording. It's usually not within 14 days, though. So I am now going to close the webinar.